Hello there. This is my fifth video for today, and that's what happens when I'm off. I love creating informational video for you guys. So I just posted a video about breast cancer, and this video is about prostate cancer. And in my clinic, I see several cases every year. A patient, 70-year-old, otherwise healthy, diagnosed with prostate cancer for 2 years. It has spread now, and he has refused treatment. So there are three main factors in treatment of prostate cancer. One, a disease is local or metastasized. Number two, overall health and life expectancy. Number three, personal goal, curative or control. Localized prostate cancer, when cancer is confined to the prostate. Example, a healthy man in his 70s with elevated PSA and biopsy showing adenocarcinoma and Gleason score of less than 7, and MRI showing no spread. Number one option, active surveillance, watchful, waiting with curative intent. Who? Older men with slow growing, low risk cancer, limited symptoms, has some health issues. He needs to have a regular PSA test, digital rectal exam, repeat biopsy, MRI scan. Goal is to avoid overtreatment until the disease show sign of progression. Okay, that is the goal. So you are actively watching. Now, number two option is surgical, which is radical prostatectomy, total removal of your prostate. So men who are healthy enough for major surgery and want a curative treatment, they want definitive treatment, they want to move on with your life, they don't want to ever think about it, okay? They got things to do, they got their dreams, they got other things to do in life. And the last thing they want is just worry in the back of your mind that I got a prostate cancer, something going to happen. Option is open or robot-assisted laparoscopic removal of prostate and nearby lymph nodes. That's why it's called radical prostatectomy. It's the removal of prostate plus surrounding lymph nodes. Side effect, urinary incontinence, erectile dysfunction, and surgical risk. Radiation therapy is another option. The patient who is unsuitable for surgery, and he wants non-surgical curative option. Okay, that bunch of option, but two of them, which is quite often used, is external beam radiation therapy called EBRT, focused radiation treatment directed at prostate. Other one is called brachytherapy. So radioactive seed is implanted directly into the prostate gland. Okay. Sometimes some patient get short-term hormone therapy, androgen deprivation treatment to improve cure rates. Focal therapy, selected cases, cryotherapy, high intensity focused ultrasound called HIFU, HIFU, or laser ablation, used in a specialized center for limited tumors, and long-term results are still being studied. Hormone therapy, androgen deprivation therapy, ADT, not standard alone for localized cancer, but may be needed to radiation treatment in intermediate and high-risk disease. Okay, now I'm going to move on to metastatic prostate cancer. Spread to the bones, lymph nodes, and other organs. Example, another man in his 70s with low back pain because of metastasis in the lower back. Could be hips, could be spine. PSA is more than 100, and biopsy is showing adenocarcinoma. So, the cornerstone of treatment in this case is ADT, androgen deprivation therapy. Goal, is to lower the testosterone, which fuel prostate cancer cells. And what are the methods? Usually, they have something called LHRH agonist, leporide, goserelin, or degarelix, or relugolix. Other option is surgical castration or chiectomy, which is not done anymore. Most men respond well initially to called hormone sensitive stage. Okay. Now, second one is combination systemic therapy. And the whole purpose is to delay resistance to hormone and prolong survival. So what they do is they combine ADT, androgen deprivation treatment, with novel hormonal agent or chemotherapy or radiopharmaceutical or radiation. So ADT plus hormone agent or chemotherapy or radiopharmaceutical or radiation to primary tumor. They have this is called combination systemic therapy. So ADT plus novel hormone agents, they use something like Zytiga, abiraterone, that's the name, insulotamide, called Xtandi, or apalutamide or darolutamide. They block androgen production or receptor activity more completely. ADT plus chemotherapy, what they do? Docetaxel or carbazitaxel, they're given in selected cases, especially in people who have high tumor burden. ADT plus radiopharmaceutical, what they do in here, they have a androgen deprivation therapy plus a radium 223 for bone metastasis, or lutetium 177 PSMA therapy in advanced cases. Other option is ADT plus radiation to primary tumor in patient who has low volume metastatic disease, only few spots. Okay, they may do prostate directed radiation to improve survival. And other treatment you might need is the bone protection and pain control. So zoledronic acid, which is bisphosphonates, or denosumab to prevent fracture, palliative radiation to painful bone lesions. This is for metastatic cases. Okay. As I said that if in rare situation the cancer progresses despite low testosterone, then they use something called PARP inhibitors, olaparib for BRCA mutated cases, or immunotherapy, pembrolizumab for MSI high or mismatch repair deficient tumors. Patients need pelvic floor physical therapy after surgery, radiation, counseling for sexual emotional health, nutrition, exercise, bone health, vitamin D, calcium, resistance training, periodic monitoring with PSA, imaging, and system review. Localized, curative, surgery, radiation, active surveillance, short-term ADT may be locally advanced, curative, control, that's the main goal, radiation plus ADT, metastatic, hormone sensitive, prolonged survival is a goal, and delay resistance, ADT, and other medication like abiraterone and izalutamide, docetaxel. And metastatic castration resistance, you have a control, palliation, and sequential hormone, chemo, radiation, targeted, and radio ligand treatment. So there are lots of information here, but this is a small video with enough information for you.